بسم الله الرحمن الرحيم. بيشرفني أكون معاكم النهاردة، وكل عام وأنتم بخير. وبشكر جمعية القلب المصرية على إتاحتها الفرصة دي ليا إن أنا أتكلم على الكسر Associated Thrombus Defragmentation A New Hope in High Risk Pulmonary Embolism. We're going to speak about management of high risk pulmonary embolism in patients who are not candidate for thrombolytic. And we're going to speak about tips and tricks for catheter assisted management, evidence, technique, and results. To make it more easy, we're going to have a small rapid case. This is a 51 years old male, not smoker, not hypertensive, not diabetic, had a motor car accident 20 days ago with right tibial fracture, neglected for 2 weeks before seeking medical advice. Orthopedic consultation was to perform tibial nail fixation surgery. After successful orthopedic surgery, the patient suddenly arrested during transportation to the ward. CPR was done with cardiac rhythm returned after few minutes. On table now, the patient is drowsy, pulse 150, tachycardic, hypotensive 80/30, hypoxic 84%, oxygen saturation of the room air with respiratory distress. After transportation to the CCU, blood gases on 60% venti mask showed hypoxia, pH was 7.4, troponin was positive, other investigation was acceptable. The first differential diagnosis is pulmonary embolism in this patient. Regarding the predisposing factor, fracture of lower limb and Geneva clinical prediction said that it is a pulmonary embolism likely. In this kind of patients, we have to do these immediate measures: oxygen supply, saline 200 and 500 milli intravenous infusion immediately, intravenous heparin 80 international unit per kg, rapid ECG, positive inotropes, echo assessment to exclude other cardiac cause and confirm right ventricular dysfunction if possible, and if necessary, we intubate the patient and put him on mechanical ventilation. This is a slide showing how to manage a high-risk pulmonary embolism patient, like our patient with shock. After initial stabilization, we do rapid CT to confirm pulmonary embolism. Then we do reperfusion therapy. In this patient, we did CT that shows largest thrombus bilaterally occluding the main pulmonary artery right and left. Cardiac consultation done after 3 hours of ICU admission. Now the patient is 160 stable blood pressure on positive inotropics, but still hypoxic with respiratory distress. ECG 130 with no specific changes, and the echo confirmed pulmonary embolism, dilated right side, pulmonary moderate tricuspid gauge, positive 60/60 sign, and positive McOneil sign. Now the patient hemodynamically unstable, so it's a high risk patient. We need immediate reperfusion therapy. Patient has recent surgery, so thrombolytic is absolute contraindication. Surgical embolectomy is not done, and the only hope is to do transcatheter mechanical defragmentation. The transcatheter defragmentation on 2013 guidelines was 2B, as you can appreciate. But on recent guidelines, it jumped to 2A. So it's becoming more and more important. So we have, as a cardiologist and a team, part of the team for pulmonary embolism management, to know how to do catheter-directed therapy with or without thrombolytic. They will summarize the two major catheter-directed treatment pathways, either with thrombolysis or without thrombolysis. So some patients we can use catheter-directed defragmentation of the thrombus with thrombolysis in high risk group who are candidate for thrombolysis, but if not candidate like our patient, so catheter therapy without thrombolysis. Without thrombolysis, we use aspiration thrombectomy, either Aspirex or angiojet, mechanical thrombectomy, rheolytic thrombectomy while angiojet, catheter, or thrombus fragmentation using pigtail, which we are going to discuss. This is what we are doing, and or combined technique by pigtail and thrombus aspiration by Aspirex. Or use defragmentation by a special ultrasound technique, guided defragmentation. If the patient is candidate for thrombolysis, they put the catheter inside, the pigtail inside, and gave him either full dose or half dose of streptokinase or tenecteplase. In our patient, this is a figure showing the angiojet catheter, 600,000 جنيه. Our Aspirex is ultrasound directed defragmentation. How to say that the procedure is successful? Patient will become hemodynamically stable, correctal hypoxia, and survive from the hospital. The overall procedure success around 87%. In two prospective cohort studies and one registry, total number of 352 patients support improvement in right ventricular function, lung perfusion, and pulmonary artery pressure in patients with intermediate high or high risk pulmonary embolism patients. However, there is no randomized controlled trial in this category, so we encourage all people in cardiology to join in making these trials. Regarding our patient, what we did an agent catheter directed defragmentation. As we said, that thrombolysis is absolute contraindication. What is the technique for catheter directed therapy? Defragmentation of the thrombus using a pigtail. نستخدم 6 فرنش femoral vein sheath جي تيب واير العادي. بندخل بالبيكتيل 5-6 فرنش ومعانا الانجكتور، وبعد لما دخلنا في الرايت فنتيكل pulmonary artery، احنا دلوقتي في الليفت pulmonary artery بنلف والواير جوه، بنلف 20 لفة يمين و20 لفة شمال. بعدين نتأكد، بيبقى فيه صعوبة في دخول الرايت pulmonary artery عادة، فأحيانا بنحقن عن طريق 50 سرنج 50 cc سيرنج والانجكتور. خلاص عرفنا مكانه بالواير pushing and pulling بتكنيك بسيطة جدا. بتقدر تدخل بالبيكتيل جوه الرايت pulmonary artery، وبرضو أيوة ندخل جواه ونشيل الواير ونبدأ نعمل الروتيشن تكنيك، والواير بيبقى في نص القصارة عشان ما يحصلش كينكينج للقصارة، وانت بتلف لازم الواير يبقى موجود. وبنعمل هيدروميكانيكال ديفراجمنتيشن كمان، بنحقن صبغة أو بنحقن سلاين مع هيبرين بال50 cc سيرنج قبل كل لفة. التايمينج أحسن وقت اللي عمل وأحسن نتيجة بتحصل في أول 3 ل6 ساعات من بداية الشوك. أول ما يبقى شوك نحسب 3 ل6 ساعات، هي دي أحسن وقت لعمل الكاثيتر دايركتد ديفراجمنتيشن. بعد 12 ساعة بتبقى النتيجة مش كويسة. لو عين شوكد 12 ساعة أو أكتر ومش متحسن، غالبا الكاثيتر دايركتد ثيرابي ما بتبقاش بتدي good results. فأحسن وقت من 3 ل6 ساعات up to 12 hours. Patient after directed catheter defragmentation, thrombus defragmentation was successful. Patient was gradually weaned من الvasopressors والأكسجين. Next 3 days blood pressure 130/80 and oxygen saturation 96% room air. Low limb duplex طبعا showed subacute DVT, so patient went on NOAC and discharged safely within 2 weeks to home. The pulmonary embolism diagnosis we have to suspect pulmonary embolism, any acute dyspnea or hemodynamic instability and sudden cardiac arrest after recent operation or long time embolization. Consider catheter-directed treatment in high-risk, intermediate, high-risk pulmonary embolism patient who has a contraindication for systemic thrombolysis، مفيش أي حل تاني، أو failed systemic thrombolysis. لازم يبقى فيه في المستشفى pulmonary embolism response team عشان ما يتأخرش العيان، لأن قلنا أحسن results في أول 3 ل 6 ساعات من بداية الشوك. وشاكر جدا مرة تاني لإتاحة الفرصة، ولو في أي تواصل أحب تتواصلوا معي على الإيميل الأكاديمي أو على الواتساب على النمرة اللي قدامكم، وشكرا مرة تانية.